Good evening, ladies and gentlemen. Sorry for being a bit late. We just had a few technical issues, but we're ready to go. My name is Chris Foster. I'll be chairing tonight's CPD presentation, and it's my privilege to introduce to you Elmarie Davoren. Ms. Elmarie Davoren is a principal investigator at the Centre for Human Metabolomics in Potchefstroom, South Africa, where she leads research and development in small molecule analysis. With over 15 years of experience in biochemistry and laboratory science, she has built deep expertise in method development, validation, and advanced instrumentation, including LC-MS, and GC-MS systems. She holds a Master's of Science in Biochemistry from Northwest University and has complemented her academic background with extensive training in laboratory quality management, clinical practice, and advanced instrumentation. Her career spans roles as laboratory technician, scientist, and now principal investigator, where she not only drives innovation in diagnostic and research applications, but also oversees staff training, project design, and quality management. Elmarie has been instrumental in coordinating international quality assurance programs, developing diagnostic methods, and managing client-focused contract research projects. Fluent in both Afrikaans and English, she combines scientific rigor with strong communication skills, making her a valuable collaborator in both academic and industry-driven projects. And she certainly is very valuable to us. So, Elmarie, thank you very much for tonight's presentation, and I look forward to what you have to say.
Okay, thank you, Prof. Thank you for that kind introduction. So, good evening, everyone. So, my presentation will focus on the diagnosis and management of trimethylaminuria, as well as its effect on the daily psychosocial functioning of these patients. So, trimethylaminuria, or is a rare metabolic disorder and is also known as fish odor syndrome. The condition was clinically first described in 1970 in The Lancet by Humbert and colleagues, who reported on a 6-year-old girl who intermittently excreted a fish-like odor. However, the disorder has been described as early as 1000 to 1400 BC in the Indian epic of the Bharata dynasty. So, in terms of prevalence, estimates range between 1 in 200,000 and 1 in a million, though this is almost certainly underreported due to lack of awareness and diagnostic access. So, certain populations, including the Ashkenazi Jewish and Eugenian groups, appear to have a higher incidence. Both males and females are affected, or can be affected, but symptoms are often more severe in women. So TMAU is also characterized by the accumulation and excretion of trimethylamine, or TMA, which is a volatile aliphatic amine, which is responsible for the odor of decomposing fish. So it may appear to be of small medical concern. In fact, patients with this disorder regard it as having a major social impact, which has consequences for their self-esteem, as well as employment, and also socially isolates them. And there have been rare cases where attempted suicide have been reported. So, as previously mentioned, this condition presents with an odor resembling that of a decomposing or rotten fish, which is due to the excess excretion of TMA in breath, saliva, sweat, urine, as well as reproductive fluids. Some patients also experience halitosis. The intensity of the odor can fluctuate depending on diet, stress, and hormonal challenges. Or changes, or as well as for medication use. What is interesting is that not everyone can smell the TMA, with some patients having reported that they are unaware of the smell. So, from a disease classification perspective, it can be divided into several categories, each differing in course, duration, and clinical presentation. So the most well-characterized form is your primary or genetic trimethylaminuria. So this results from a biallelic pathogenic variant in the FMO3. That's a flavomonoxygenase 3 gene, which encodes the flavin-containing monooxygenase 3 enzyme in the liver. Primary TMAU follows an autosomal recessive inheritance pattern with more than 40 disease-causing variants that have been described. So these variants lead to either complete loss or significant reduction of the enzyme activity. And according to the clinical gene code of this disorder, the estimated carrier frequency for severe TMAU in a British Caucasian population is around 0.5 to 1%. That is roughly 1 in 40,000 individuals. But there may be significant variation in carrier status in different ethnic groups. So the resulting impairment in the N-oxidation capacity accounts for most cases of the TMAU reported in literature. So the condition is also lifelong, but symptoms may fluctuate with factors such as diet, hormonal changes, and overall health status. So in contrast, the secondary trimethylaminuria is not as directly related to genetic etiology. It arises due to external factors or other medical conditions that interfere with the TMA metabolism. And one of the most common causes is an overload of TMA precursors in the diet, um, particularly foods rich in choline, carnitine, and trimethyl N oxide, which is found in seafood and eggs. And in these cases, the liver's FMO3 enzyme may simply be overwhelmed by the substrate load. So secondary TMAU can also develop in the context of liver disease, where the enzyme's function is reduced or due to hormonal fluctuations during menstruation or puberty, which then can transiently worsen the odor symptoms. There's also certain medications or environmental chemicals that may inhibit the FMO3 enzyme, and that this then mimics the features of genetic TMAU. So this form of TMAU can occur at any age and is often intermittent or reversible. But once the underlying trigger, if it's diet, infection, or drug exposure is corrected, the symptoms may improve or even disappear. So overall, secondary forms are milder than the genetic form. So let's now look more closely at the metabolic pathway, which underlines this disorder. So trimethylamine N oxide, or TMAO, is a water-soluble molecule with diverse physiological roles. So in marine organisms, it functions as an osmolyte, which stabilizes proteins under high-pressure environments. And then in humans, however, TMAO is the end product of a metabolic pathway that begins in the gut and ends in the liver. So the synthesis of TMAO occurs in two key steps. So first, the gut microbiota converts dietary nutrients like choline, carnitine, and betaine here into TMA. Choline is abundant in eggs, meat, and dairy products, whereas L-carnitine is primarily found in red meat, and betaine is present in plant-based foods such as wheat and spinach. So TMA and the above precursors can then be converted into TMAO through specific bacterial enzymes, and the known enzymatic pathways are choline TMA lyase, carnitine monooxygenase, betaine reductase, and TMAO reductase. So once formed, TMA is then readily observed through the intestinal mucosa and enters the portal circulation, where it is transported to the liver. So in individuals with normal enzymatic activity, TMA undergoes oxidation to TMAO, which is a non-odorous and water-soluble compound. This reaction is catalyzed by the flavin-containing monooxygenase 3 enzyme, which is located in the hepatic microsomes. So FMO3 introduces an oxygen atom onto the nitrogen of TMAO, and then it forms then TMAO. And then the enzymatic oxidation effectively neutralizes the strong fishy odor of TMA and allows for its renal excretion without volatilization. So there are also alternative routes of TMAO excretion, which includes perspiration via feces or exhaled air, and as well as other bodily fluids. So diagnosis of TMAU involves a combination of biochemical and genetic testing. So the first step is a biochemical confirmation through urine analysis, where both the TMA and TMAO levels are measured via a loading test. So this analysis helps to determine the FMO3 enzyme activities oxidation capacity. So that is basically how efficiently your TMA is being converted to TMAO. So thus far, 3 loading protocols have been described in literature. Historically, and what is still being used in some centers today, is the choline loading test, where people get choline that they drink, and the urine samples are collected, and the TMA and TMAO levels are determined. before and after choline consumption. There's also a protocol followed in Nijmegen, which consists of eating a marine fish meal and also subsequent collection of urine over a 6-hour period after the meal, or sampling to 12 hours after the meal has been provided with some, and then some patients has a positive diagnosis. Finally, the last loading protocol is a direct loading with a 600 milligram dose of TMA, and that was found to be the most effective in the diagnosis of severe and mild cases. So this approach assures sufficient substrate to maximize flux through the oxidizing system, and then TMA and TMAO is measured before and after to determine the oxidation capacity. So it is important, however, to note that some loading tests may fail to or be borderline abnormal, as adequate excretion of metabolic products is not always optimal. So the reason for this may be the composition of the gut microbiome or due to delayed gastric emptying. And then for this reason, genetic testing is also recommended to determine if there's a strong suspicion of primary TMAU. So what we do at our laboratory is we use a standardized TMA loading protocol. So the loading mixture is prepared by adding a TMA solution to 250 ml of orange juice. And then this orange juice masks the strong odor of TMA. The mixture is frozen and then couriered on dry ice to the referring pathology laboratory. And then on the day of testing, a baseline urine sample is collected before ingestion of the mixture. The patient then consume the TMA orange juice solution, and then following administration, urine samples are collected every hour for 4 hours, each clearly labeled to document the collection time point. Okay, so the entire procedure is performed under medical supervision, and a questionnaire is also completed by the patient to capture any symptom changes or side effects. Samples are immediately frozen after each collection to preserve the analyte stability and to maintain the cold chain, which is importantly, testing is not performed during or near the patient's menstrual period, as hormonal fluctuations can transiently alter enzyme activity and confound the results. So for each patient, EDTA blood is also collected for DNA extraction, and this enables then molecular confirmation. The genomic DNA is isolated. The PCR amplification is performed on exons 2 through 9 of the FMO3 gene, which using primers specific to the protein coding regions. So at our laboratory, we have tested more than 10 individuals who suspected they might have TMAU. So interestingly, the majority of these patients were female, and most were in their 30s at the time of testing. When we examined their results, the majority of cases were identified as secondary TMAU, which was likely linked to dietary gut microbiome or hepatic factors affecting TMA metabolism. Only one patient was confirmed to have a primary TMAU, but that resulted from a genetic deficiency in the FMO3 gene. Okay, so while there is no definitive cure, symptoms can often be significantly reduced through carefully guided interventions, which are tailored to the individual's metabolic capacity and lifestyle. So when it comes to effective management, it requires a multifaceted approach, combining dietary modifications, supportive therapies, and patient education. So, and these strategies can be broadly classified into 4 main strategies. So that first off, limiting the precursor intake, protonating or trapping the TMA, targeting the gut metabolism, and targeting the FMO3 enzyme itself. So dietary management remains the cornerstone of TMAU treatment, since TMA is generated primarily from dietary precursors such as choline, carnitine. The restriction of these compounds can significantly reduce odor production. So foods particularly rich in these precursors, that's eggs, red meat, soy products, certain vegetables such as Brussels sprouts and broccoli are avoided, and then as well as marine fish or crustaceans, which are also high in TMAO. So, however, this form of dietary restriction requires careful supervision. So choline is an essential nutrient vital for cell membrane synthesis, lipid metabolism, and brain development, particularly in the fetus and young child. So therefore, excessive restriction can be harmful, especially in pregnant or lactating women, in infants and children, where the choline demands are higher. So interestingly, Brussels sprouts and other brassicas not only contain choline, but also contain indoles that inhibit FMO3 enzyme activity, so which further then aggravates the condition. So their intake should also be limited, even if they are not major choline sources. So because choline metabolism is linked to folate, low choline diets can increase folate requirements, and these patients may need supplementation to maintain their methylation balance. So nutritionally balanced choline-restricted diets have been developed and can be adapted for individual use, but again, this should always be supervised to prevent secondary deficiencies or neurological complications. So the next approach focuses on neutralizing or trapping TMA that is already formed. So since TMA is a strong base with a pKa of approximately 9.8, it becomes volatile at an alkaline pH. So maintaining an acidic skin environment close to pH of 5.5 to 6.5 keeps the TMA in its protonated and thus non-volatile salt form. So therefore, the use of acidic soaps, shampoos, and body lotions is recommended to reduce odor emission, which then facilitates the washing away of the salt form. So there's also two oral compounds, activated charcoal and copper chlorophyllin, that has been shown to decrease urinary TMA concentration, which by sequestering the compound within the gut. So, however, their mechanisms are not specific and they may also capture other metabolites. So long-term or repeated use should be undertaken with caution. So because TMA production occurs mainly in the gut microbiota, modulating the intestinal bacteria represents another major therapeutic target. So short courses of antibiotics have been shown to reduce bacterial production of TMA from dietary sources, and the most commonly used agents include metronidazole and neomycin. So metronidazole has demonstrated variable outcomes, with some patients experiencing up to a threefold decrease in urinary TMA, while others show minimal improvement. So combination regimens that include such as metronidazole with neomycin appear to be more effective, though they come with a risk of gut dysbiosis. So long-term antibiotic use is not recommended as it promotes antimicrobial resistance and disrupts also the normal gut flora. So given the limitations of antibiotics, probiotics, and fecal microbiota transplantation are emerging as potential alternatives. So in a small number of cases, the fecal microbiota transplantation following antibiotic therapy led to a temporary improvement in odor for several months. However, symptoms typically reappeared within a year, which indicates that repeated treatments may be necessary and that microbiota reconstitution is slow. So several probiotic strains have also shown the ability to reduce TMA levels in vitro, though human trials remain limited. So enhancing residual FMO3 enzyme activity represents also another therapeutic focus. So riboflavin, which is the precursor of the FAD prosthetic group of FMO3, can increase enzyme efficiency in individuals with a mild residual activity. So in children, riboflavin supplementation should be monitored carefully to avoid gastrointestinal side effects. And then certain dietary compounds and medication can also inhibit FMO3 activity. In addition, several drugs are metabolized by FMO3 and can compete with TMA, which then worsens the symptoms or reducing the drug clearance. So such medication should be avoided or substituted where possible. So recent research has focused on inhibiting the microbial enzymes responsible for converting choline into TMA, particularly choline TMA lyases. A variety of compounds have shown promise, including phytochemicals, choline analogs, as well as flavonoids. So one notable compound, 3-D-methyl-1-butanol, DMB, effectively inhibits microbial choline TMA lyase activity in preclinical studies, thereby reducing TMA production at its source. So this is a video that's available on YouTube just to give people an idea of how the patient with TMA feels about the disorder or their personal experiences. Just gonna...
Come on then, Tom.
Thomas is one of an estimated 300 people in Britain who has fish odor syndrome. It's a metabolic disorder that causes sufferers to emit a variety of unpleasant smells,
You'll be tired, right?
from rotting fish to stale sweat to even faeces.
We first noticed it when we started weaning him, when he was about 6 months. We used to notice it on his hair and we used to think it was crazy, you know, he'd smell of fish, which we thought was really strange. We went to the doctors and things about it, but they sort of passed it off and didn't really know. I think they thought I was mad, really, saying my son smelled of fish.
Fish odour syndrome, or TMAU, is incurable, and Thomas's life is dominated by his condition. Rachel Collins has no idea what's wrong with her, but she's been plagued by a smell since her teens. It's an odour that's obvious to those around her.
I remember I was in a shoe shop with my mum and my sister. They both just suddenly said, "Oh, what's that awful smell?" And we all realised that it was me, and I just felt really embarrassed. Just really strong body odour, but very, very bad, very offensive.
Rachel's smell problems continued on and off throughout her university years.
I'd been out one night to the pub with lots of people, and the next day I overheard people commenting, and I realised then that it had happened the night before in the pub. People made comments like they got me a pint, instead of a pint of beer, a pint of BO, that kind of thing. Just little comments like that.
The only thing that Rachel can predict about her problem is that it will come at the worst of times.
If it could be the most embarrassing, humiliating situation for it to happen, then it would happen in that situation. So if I was at home with my family, it wouldn't happen. But if I was out in the pub with lots of people that perhaps I didn't know, that's when it would happen.
Lack of social life apart, the idea of being intimate with a man is a scary prospect. Rachel understands only too well the problems of smelling bad. It has made her feel so isolated that she spent most of her 20s travelling in Asia.
It just feels much more relaxed, almost like you can kind of breathe there more easily, you can just be yourself.
Now 32, Rachel is determined to start a life back in the UK. But she's not finding it easy.
As soon as the plane lands in England, it feels as if you're walking into a sterile environment where it's almost as if nothing is real. I feel a sense of dread whenever I come back, and I feel almost trapped, I suppose. Just the way that society is, I don't fit in, I'm not acceptable here.
Constantly fearing a smell attack, Rachel rarely socialises with anyone else but her sister Esther.
Can I get a pint and a half?
Esther is her only confidant.
But then instead of maturing it like a treasure, I've kind of noticed the last couple of days people kind of moving away from me.
I haven't noticed anything.
It makes me more worried that I'm smelling bad.
It's one of those things you get a whiff of, and it's quite strong and it's quite a sour kind of smell. I can reassure you about times I've been with you, but I mean...
Rachel's odour problems makes relationships with men almost impossible.
I would just be conscious that they were feeling very repulsed by me. I've just felt so ashamed and so embarrassed and guilty because it's affecting other people that you're around. And I know it's not nice, and I'm aware of that, and that's what kind of killed me, that it was kind of subjecting other people to this awful smell.
I think she had a boyfriend a couple of years ago for a month or so, and they'd see each other every now and then. And it seemed to be going all right, but then it just never got past a certain point.
I just felt like a freak, really. Just felt very, very ugly.
We still talk about the shopping from still there.
Until only last week, Rachel had believed she was alone with her mystery condition. But her life is about to be turned upside down. Rachel has made an exciting discovery. She has uncovered fish odour syndrome on the internet and recognises the symptoms as similar to her own.
I just went on the internet and I came across a chat room. Lots of people had written their stories and it just sounded exactly similar to me. For all this time, I thought that I was the only person, really. And then all of a sudden, I was suddenly aware that there were other people that had it as well, and that perhaps there was a name for it. It was an actual recognised condition.
Still not sure whether this was the condition she had, Rachel and her mum visit University College London Hospital to see a leading specialist in fish odour syndrome.
What is it you think smells? Is it your sweat, your skin?
It's sweat, it's my underarms. It's like that nervous, stressed sweat.
Mm-hmm. And what sort of smell was it?
Body odour, like kind of really bad, kind of rancid kind of smell.
The inherited diseases that can cause this sort of problem tend to cause all of your secretions in the body to smell, and it has a characteristic smell of rotting fish,
Right.
which it doesn't sound like is something you've necessarily noticed. But we can certainly test for that.
Right.
So we just pop you on the couch over here. So are you aware of a smell at the moment? Not really. Let's start with your hat, see if I can... Anything off there.
This is the ultimate indignity for Rachel, being smelt by a doctor.
Sit you back down again.
Dr. Lackman doubts whether she is suffering from fish odour syndrome, but sends her for blood tests anyway.
Okay, nice to see you.
It's pretty humiliating, I think, to have a condition with a name like that and with symptoms like that. It's not something that you'd want to tell lots of people about, and it just feels it's not nice, really.
Rachel now has an agonising 3-week wait to know whether she has a disease that she finds too embarrassing to name. For Rachel, paranoia about personal smell rules her life. Today, she's back at the University College London Hospital to find out if the smell that has dominated the way she lives is fish odour syndrome.
I'm feeling a bit apprehensive about it, really, but not quite sure what's going to happen. I really don't think it is that condition, but if it is, then I'll be quite surprised.
Okay, so you're back for the results of the test we sent off last time. So we sent the urine off to Sheffield, and the results coming back show that there is trimethylamine in the urine, which means that you do have trimethylaminuria.
Right.
Which is a diagnosis, so that's good from that point of view.
After 14 years of feeling like someone who could not control her odour, Rachel has become the 301st person to be diagnosed with fish odour syndrome in the UK.
And it doesn't have to be fish odour.
It's very much like ammonia, and I think it can smell ammoniacal, like smelling salts, if you like, but probably, and that is quite unpleasant. But I wouldn't necessarily say it would smell like fish to everybody, no.
I was quite surprised by that, wasn't expecting that. And I feel quite relieved, actually. It's a long time not knowing what it was and just thinking it was, you know, it was me, that it was my fault. And now I know that it's a medical condition, so it's a relief, really, to have a diagnosis.
Free from the cycle of blaming herself, Rachel can now learn about a real condition and find treatment.
Come on then.
Okay, so there has been a couple of articles published in recent years about the impact of this disorder on patients' lives. For the purposes of this presentation, I will only focus on the study that was done by Roddy in 2019. So the aim of the study was to explore the psychosocial aspects of adults living with TMAU through semi-structured interviews. They hope that this study would inform care pathways and also help healthcare practitioners to formulate effective, person-centered treatment plans and interventions. So the researchers recruited 6 people having a confirmed diagnosis of TMAU, which was either confirmed by biochemical testing or FMO3 gene testing. All the patients in the study were following a choline and TMA restricted diet and were taking riboflavin 100 milligrams once daily. The patient's demographic data, as well as the genetic and biochemical data, is summarized in this table. All the participants were Irish Caucasian. There were 3 males and 3 females. 5 of the participants were employed and 1 was retired, with the median age of the cohort being 36.5 years. So most of the participants in the study completed school and obtained a university degree. The researchers designed a demographic questionnaire as well as a semi-structured interview guide, which was administered to participants prior to a one-on-one session that lasted between 34 and 56 minutes. So the interview guide was based on themes that emerged during standard of care support groups for individuals with this disorder. And the questions were based around areas of daily living, impact on social, educational, professional, and personal functions, as well as experiences of healthcare practitioners and the healthcare system. And all the interviews were recorded, transcribed, and analyzed using thematic analysis. So this allowed the researchers to identify recurring patterns as well as psychological themes across individual narratives. And then there were 4 key themes that emerged. So the first was the journey to diagnosis. So for most of the patients, it was a long and difficult path. The early experiences with this disorder was of shame, dread, and embarrassment. Many of the individuals were dismissed by healthcare professionals, and diagnosis brought relief and validation. The positive impact of special care and support groups was important and really helped them. And then even some did remain dismayed at living with a chronic incurable disorder. So the emotional impact, so there's constant fear, anxiety, and paranoia. There's also dysfunctional thinking, so the patients catastrophize, they overgeneralize, they also mind read, think that feelings of shame, guilt, and embarrassment, which led to low self-worth and poor self-esteem. The negative comments from others also caused lasting trauma, and some reported suicidal ideation. There was also mixed experiences with mental health professionals, but support groups really helped most of the participants with getting to grips with the disorder. Then navigating daily life. It strengthened friendships as well as intimacy and trust. Some participants avoided or ended relationships to reduce the stress. They were relieved when there was social invitation ceased. Use of alcohol as coping tool in social interactions took place. They was concerned about passing the condition to their children, which also added to their distress. So with regard to relationship, the disclosure varied. So some hid the conditions, where others openly shared the condition. It also strained friendships. Participants avoided or ended relationships, and then relief. Oh, da, da, da. Ah, sorry, guys. Yes, relationships. Okay, so this is what happens. This is what I was curious to know. If I do a Google search on TMAU in South Africa, what would I get? And this, I was actually surprised because it showed several local media and online articles which featured individuals who were either suspected that they had the disorder or had received a formal diagnosis. This article was about a student who, and I would recommend people to read the article. It was kind of interesting, because he only noticed it when he started going to the gym and eating more eggs and red meat. This is a video that someone in Neisner made about the condition and what it is, and she tries to explain what the effect of it on her life. So TMA is definitely um, here in our country, and it does definitely affect our patients and people. So this is a case report that we published in the beginning of this year. The patient had a classical presentation of primary TMAU. She was 11 years old when she was referred for biochemical and genetic testing after presenting with a persistent fish-like body odor, which was most noticeable around menstruation and after consuming seafood. She experienced significant social distress and teasing at school, and this is what really prompted further investigation by her healthcare team. So during the loading test, she did not personally perceive a difference in odor intensity before and after the test. However, the laboratory reported a strong fishy odor, which suggests that she might be anosmic to TMA. This is a trait found in around 7% of the population. So biochemical analysis confirmed primary TMAU due to the deficient FMO3 enzyme activity, and Sanger sequencing identified the specific missense variants along with the more common variants. So following diagnosis, the patient began dietary management to recommendations made by the National Human Genome Research Institute, and this includes initially, after consultation with a geneticist, activated charcoal was taken twice daily, accompanied by copper chlorophyll taken 3 times daily after meals for 3 weeks. The clinicians also prescribed antibiotics twice annually to maintain a healthy microbiome. And in addition, soaps with a moderate pH were recommended. Okay, so by maintaining a neutral skin pH, as we discussed earlier, less volatile TMA secretion was experienced. There was also cofactor supplementation, specifically riboflavin. And then the management of her condition has improved considerably as she tries to limit triggers associated with TMAU. She is currently a functioning young adult. She's now 19 years old, and she makes a valued contribution to society. This also emphasizes the need for increased awareness and diagnostic services for TMAU in South Africa, where affected individuals often remain untested despite clear clinical symptoms. So in conclusion, TMAU is a rare metabolic condition, and it results from the accumulation of TMA. TMAU exists along a continuum from the severe inherited enzyme deficiency of primary TMAU to a milder acquired or transient forms where enzyme function is temporarily compromised or overwhelmed. While TMAU is not life-threatening, it really has a profound effect on the quality of life of these patients. So many individuals experience stigma, social isolation, depression, and even suicidal thoughts due to the psychological burden of the condition. So because there is currently no definitive cure, the treatment focuses on management, and and most importantly, we should provide emotional and psychological support to the patients. So this management requires a multidisciplinary approach, which brings together biochemists, clinicians, dietitians, as well as mental health professionals. And then through the awareness, early diagnosis, as well as compassionate care, we can help the patients not only control their symptoms, but we can also restore their confidence and quality of life. Okay, thank you. Any questions or comments?
Thank you, Elmarie. If people have questions, they're welcome to post them in the Q&A section while we give people opportunity just to gather their thoughts. Maybe I can ask you one or two questions. This topic actually also came up this morning as well when we had other discussions.
Yes.
And TMA and TMAO have been linked to cardiovascular disease. And now when you presented, I couldn't remember this morning, but now when you presented, I quickly checked, and it's actually the TMAO that has been linked to accelerated atherosclerosis.
Okay.
And I always say that these patients are very valuable because they are actually natural knockout models. So the question that I have in my mind is, are these patients protected from cardiovascular disease because they do not form TMAO? So did you read anything about that in all of your readings about fish odor disease?
Prof, I think I did come across some articles where they discussed it, but I don't think it's anything definitive yet. Like Prof. Chris Hendricks said this morning, we need more data before we can really say yes, they do, or are protected or not.
Okay, then Sibongile is saying, thank you for an interesting talk, well presented. I think it's definitely underdiagnosed. The patients that we diagnosed, I'm wondering now, because of this functional potentially overwhelming the FMO3 enzyme, if the heterozygous patients is more inclined to present with secondary TMA fish odor disease. So in our patient series, those that had secondary TMAO, were any of them heterozygous?
Yes, I think so, if I remember correctly.
And there's also an idea that literature supports.
Yes. I think for certain polymorphisms or something.
Yeah,
I remember
if you just have one allele that's dysfunctional, and in other words,
functional.
50% enzyme activity, and you
Yes.
then get a high load of choline or other, whether it would overwhelm the enzyme.
It could. I think I did see something of that in our article that we wrote about a certain heterozygous missense, mutations. There's a specific, there are two, I think, that's associated with more the secondary type.
Okay. Okay, that's very interesting. It's unfortunately, like we discussed, also the testing is very expensive, but perhaps if we batch the patients, in other words, if you want to be tested, you go onto a waiting list until we have a certain number of patients, and then we perform the analyses, and we can perhaps do it at a much lower rate and then enable more patients to get a diagnosis. There's certainly not just one patient in South Africa, I can imagine.
But with primary, no, I don't think so either.
The primary patient that we have, is it a homozygous or compound heterozygous patient?
She had, well, I can check for Prof. Okay.
Okay. No, I was just I just wanted to see if there's perhaps any possibility of a founder effect or something.
It was a new mutation that they've noted, but was which is linked to the FMAO region, but it wasn't previously described. And I
Okay.
know it's a
Okay.
missense mutation. All of them share the missense mutation.
Okay. And I can't remember this now. So why did we opt for NMR and not LCMS? I can't remember anymore.
Prof, so these compounds are very volatile. So so it's much easier to detect them or to analyze them on NMR. Yeah.
Okay.
And the
Yeah.
nice thing about NMR is there are a couple of other malodor disorders which is also been discussed or that you can then potentially also see in the same sample run. So it's not with like a specific test setup and you only look for TMA, TMAO. Now with NMR, you can see the whole sample and it's not distracted. Or yes, the sample prep is very easy, non-destructive.
Okay. Maybe this is also a nice target for a point of care test. So if you're a patient and because I know that,
Think.
quite a few of the patients, they don't always know if they smell or not. So if you've got a quick point of care test that you can just test sweat or whatever,
Yeah.
that could be an interesting application for a point of care assay.
That could be very nice, and if it tastes positive, then you can ask for more advanced testing.
Yeah, or just perhaps follow stricter diet, don't go out that evening or whatever, something along that line.
Yes.
Okay, well, it seems
Um,
like it's a bit of a dialogue here. No other questions coming in from the
Yeah.
audience. Well,
Okay.
okay, then, Elmarie, thanks again. It was very interesting presentation, very interesting disease as well. I just want to just make the comment again to ensure the audience that this presentations were sponsored by Sanofi, but Sanofi has no input in the topics that we select. And neither the content of the presentation, but we're very thankful for the sponsorship. It really enables us to improve the quality of the presentations. I'd like to thank everybody in the audience who joined. I know it's late in the year and it's a very busy time of the year, so thank you very much for joining. Thank you again, Elmarie, and we look forward to seeing you next week. And with that, goodbye.
Bye.